Hey, good morning, good afternoon, good evening, everyone. I'm back. This is Patience. Today, I'm gonna continue on physiological integrity. Physiological integrity. How are you preparing for the NCLEX so far? Please let me know how you are doing. I want you to get a book and a pen, write something down as I go along with the discussion. If you have any further questions, any further concerns, do not hesitate to send me an email, send me a text, let me know what's going on with you. You really need to understand that this test plan that I'm tackling describe what the NCLEX wants you to know before you sit in for that exam. Don't sit or don't go to write that exam ignorantly without understanding the component of the test that, or the component of things that you will be tested on. So these are some of the topics. If I am discussing and you have a concern, you don't understand any topic, please refer to your content book. This is just a review portion of the main content. So I don't talk about the anatomy. I don't talk about the detailed anatomy of it. So today, let's go to physiological integrity again. This is video number 5. Video number 5. So under physiological integrity, basic care and comfort, the NCLEX has the test plan divided into sections, and there are 7 sections under that. We have the mobility and immobility. That was my video number 1. Conditions limiting mobility, video number 2. Interventions to promote comfort, video number 3. Musculoskeletal system or musculoskeletal trauma, video number 4. This is video number 5, and I have 2 more videos to finish the test plan or the candidate performance report for physiological integrity, basic care, and comfort. And the 2 sections left are nutrition and elimination. So let's go straight to talk about rest and sleep disturbances. Rest and sleep disturbances. So for a patient who has left their house with the fear that they can no longer take care of their own sickness, they have been sick for days and they cannot take care of it, and now they think they need to seek medical intervention, they need to seek your nursing expertise. This is a new environment. This is not usual of them. And the fear of coming to the hospital alone is enough to make them sleepless. So for some patients who never want to go to the hospital until they have no choice, they have no option, this is the category most people find themselves in. Apart from the vulnerable population who don't have a choice than to be taken to the hospital for 1 or 2 reasons, we have the elderly population, we have the sick, that the disabled. Sometimes they are not able to make decisions for themselves. But for you and I, or for some people who are still in the working category, who are strong, some elderly people are still strong and they just don't want to be in the hospital. So if a patient happens to be in the hospital, what will you do? What will you assess for this patient? Because that is not their normal environment. For example, knowing that people dying in the hospital and there's anxiety. So this will disturb their sleep pattern. So for a hospitalized client, you want to assess them for restlessness. You want to assess them for fatigue, inability to concentrate, irritability, depression, hallucinations. Some of them can start having hallucinations after extended period of sleeplessness. So if a patient hasn't slept for some time, they can start having hallucinations. How will you diagnose a patient who has been hospitalized and is having sleep and rest problems? The diagnosis, what is sleep in the first place? You need to know what sleep is. It's a basic physiological need. When you look at the Maslow hierarchy of needs, we have basic needs. So sleep is a basic physiological need. It allows the body to repair its own damaged cells. It enhances removal of waste product from the body. Sleep restores tissues to maximize functional ability before another activity is begin. So you sleep, it relaxes your body to gain your functional ability before the next day you start your activity. Sleep, I'm not going to talk about sleep. I'll be talking about rest. So rest restores your tissues and restores maximum functional ability before you start another activities. Now let's talk about sleep. What is sleep? It's a basic physiological need as well. In as much as you need to rest, you need to sleep. So although the purpose and the reason for it is not clear, the purpose for sleep is not so clear to anyone. Researchers have done research, but possibly there are theories that talk about sleep. And some of the theories, the people that came up with their theories said sleep is used to restore balance among parts of the central nervous system. As you and I can testify that the central nervous system controls the sleep mechanism. So it's used to restore function of it, to balance it, so that after a whole long day, you close your eyes, you have a good rest as well. So sleep and rest move together, and they are both basic needs and the Maslow hierarchy of needs. To restore balance, sleep will also so to mediate stress, anxiety, and tension, sleep will help mediate anxiety, stress, and tension, and to also help a person to cope with your daily activities. So for someone who has not gotten rest for several days, it is very tough to have them cope for their activities of daily living. They have problems. You cannot cope. If you are sleepy, I don't know if you have ever been sleepy yourself and you just don't want to sleep, which you have no control. Naturally, you are pushed to sleep. That's why you see some drivers sleeping behind the wheel. So we have causes of disturbance. What caused the disturbance? Why do people have problems resting and problems sleeping? It's because of stress. They are stressed. You have a lot to think about. You have a lot to study. Using you who is preparing for the NCLEX as an example, what will cause you to be sleepless? Fear and anxiety. You are scared that you haven't learned anything. You are scared that you don't want to go and fail. You are stressed, your brain. So you're pushing your brain to study all day, all night. But remember to get rest in between your study periods, okay? Drugs. People who use barbiturates, hypnotics. These are drugs that can cause you to be sleepless and restless. An unfamiliar environment, that's where the hospitalized clients fall. It's not a familiar environment, so you are scared to sleep. The potential nursing diagnosis that you are concerned about will be sleep pattern disturbance. A patient's sleep pattern will be disturbed. So activities intolerance and injury risk for. Okay, so you are also worried about injury, which is risk for injury. You are worried about that. What will you do for a patient who is admitted or who has rest and sleep problems? You want to establish a database on clients' pattern of sleep. You have to help them to come up with a plan on how to sleep. So you want to give in blocks of time that will allow uninterrupted periods of rest and sleep. Please, most people don't even want to be in the hospital because they feel like every minute they are coming in to take my vitals. Every minute they are coming in to bother me. When the patient is just about to catch a nap, somebody knock on the door. It's so stressful. So you allow them periods of uninterrupted rest and sleep. Remove unpleasant odors. Orders that is not in the interest of the patient, take it out of the way. Avoid unnecessary lighting or noise. No loud TV, no loud music, avoid them. Avoid excessive warm or cold or cool temperatures. So if you are too cold, it's hard to sleep. If you are too hot, you can imagine. Reposition client as appropriate. You want to help them with positioning. You want to spend time with the client. Give an unhurried bath up. Don't rush them. Let them have a good shower that will relax their muscles. Then straighten and replace wrinkled or swelled linens. So linens that are swelled. If you're sleeping on a wet cloth, you are not comfortable. So sleep will be a problem. Give warm, non-stimulating beverages. So let them drink some warm tea, something warm to warm them up. So you give pain medication if they have pain, preferably for them to sleep just before they sleep, and it will interfere with their, like, don't give medications that will interfere, that will make them more anxious. Like I spoke about barbiturates and hypnotics. Then you want to provide diversionary and occupational activities during the day to relieve boredom and utilize night time for sleep. So some people just don't know how to balance between the day and the night time. So you have to help them to come up with activities that will keep them busy. If you haven't seen this done before, use the nursing home patients as an example. They have day activities, day programs that they will go to, and at night they go to their bed uninterrupted. So you want to explain their treatment activities ahead of time. You want to listen to their concerns of sleep issues. Then you want to give a thorough orientation to the hospital setting. So you want to make them comfortable. So if somebody comes to your house and just walk in, you want to orientate the person. So the nurse has to orientate the patient to the hospital environment. Sometimes you give them the papers, you let them know their rights and responsibilities, what is expected of them, and what they're supposed to do in here, and how their daily schedule is going to be like. So it's all the nurse's responsibility to take care of them. So if you are taking care of a patient who has sleep and rest problems, when you evaluating, because you have implemented all these activities for the patient, then you want to find out, is the client able to fall asleep and stay asleep for a couple of hours? Then you want to also have the client to be comfortable. So have you been able to maintain comfort? This will be how you evaluate a client. Now let's talk about the elderly client. The elderly clients. So the elderly client, they have difficulty getting to sleep. They wake up early in the morning, and then brief periods of wakefulness during the night. So at night they keep waking up, and in the morning they wake up so early. This reminds me. So we have times that our parents just don't want you to sleep, like from 7 p.m. and in the morning. They want to make sure that you had a good night's sleep. They will knock on your door to wake you up. So the elderly people cannot just sleep all day, all night, like the younger people who work and they want to even stay in bed on their phone and they sleep late. Diagnosis. So an elderly person with sleep problems, what are your diagnoses? They will have sleep pattern changes with advancing age. So as they grow older, their sleep pattern is going to change. So levels of deep sleep occurs less frequently. They don't sleep so deep. So the person is sleeping and you walk in and they wake up. That's their problem. Implementation. What will you do for them? So for a patient who is having sleep problem, what will you do? So you want to establish regularly scheduled sleep patterns for them. Regularly, you want them to be able to be like, okay, it is time for siesta. You have to stay in bed. So You tell them to go to bed, and then you also help them come out of bed. You give them same time schedule every day. Then you avoid caffeinated beverage late in the night. So if they took coffee late in the night, you can imagine they're going to stay awake all night. So you also want to establish a bedtime ritual, like warm bath, warm milk. You tell them to exercise regularly to keep their body fit. You know, exercise will also help in rest and sleep. If they are unable to sleep, perform quiet activity or read. Tell them to do some activity that is quiet. They can just lie down and meditate, and then they read a book, they read a newspaper, and then they'll go to sleep. Bedrooms should be well ventilated and humidified. Shouldn't be a dry room. Reduce daytime napping and inactivity. So keep them busy in the daytime. Evaluate them for sleep apnea. That's sitting down and sleeping or problem sleeping. Evaluate for nocturia. Nocturia. Then you want to evaluate. Nocturia means urinating frequently in the night. So because they wake up often, you see them going to the bathroom every night. You want to evaluate if they have that problem and what is the problem. Could it be a medical problem underlying it? Then you want to evaluate them to see if the client is able to wake up and look refreshed. Sometimes somebody just wake up and look stressed, and you can already see. So you also want to question if they have sleep challenges. Daily activities of daily living will be affected. So your evaluation should also be towards that. Have they been able to maintain activities of daily living? Have they been able to carry them out without assistance? Then you want to make sure that if they are not able to, then you want to go back and check, what did I do? Your implementations has to work. Let's talk about sleep apnea syndrome. Sleep apnea syndrome. This is client snores loudly. When you see a patient with sleep apnea, they snore loudly. Sleep apnea is basically snoring. Snoring, okay? It can be annoying. So client snores loudly, stops breathing for 10 seconds or more, then awakens abruptly with loud snore and multiple nighttime wakings. Is something. Excessive daytime sleepiness and fatigue. Daytime they'll be sleepy and they look fatigued because they didn't sleep good. They're sleeping, they sit down, they like, and then for a while they go, and then they open their eyes and go back again. Then we have morning headaches. People with sleep apnea syndrome, those who snore, they have morning headaches. They have sore throat problems. They have personality and behavioral changes because their mind doesn't get good rest. So their behavior is just off. They are stressed. They have fatigue. Dysarrhythmias, hypertension, increased risk for stroke, myocardial infarction, and heart failure. So they have cardiovascular disturbances, cardiovascular problems. Take notes. So for people with sleep apnea syndrome, they're at higher risk for cardiovascular system disorders. Diagnosis, it always occurs in older people. Which group of people? Older people, those who are overweight, like obese men, overweight men, they snore a lot. Elderly people, they also snore. People with their necks, like people with thick necks, those who have, like, you see these heavy flaps in the neck, those who have those heavy flaps in the neck, and their neck is very thick, they are at higher risk for snoring. Then those who smoke, smokers too. So if you are diagnosing them, what do they use to diagnose them? They can do an EKG, oxygen saturation levels. You want to know how much is the person's oxygen saturation level. Now, let me ask you a question. You remember we did the FiO2 calculation. Please, if you don't remember that, go and check it, and then you let me know. The FiO2, the oxygen percentage. If I tell you that, oh, the client is supposed to get 32% of oxygen, how many liters will you set it on the oxygen tank? 32% of oxygen, how many liters will you set it? So the types of sleep apnea syndrome will be obstructive. This is lack of airflow to occlusion of the pharynx. There's lack of airflow due to occlusion of the pharynx. Then central, we have the central sleep apnea, this cessation of airflow and respiratory movement. Then we have the mixed sleep apnea. It's a combination of central and obstructive apnea within an episode. So the implementation, what will you do for them? What is your nursing intervention? You want to help them avoid alcohol. You want to educate them on the need not to take alcohol and medications that will suppress the upper respiratory airway. Overweight, you want to teach them about dietary management, dietary process and activities that will help maintain their diet, their weight. For severe cases, if the client is hypoxic and hypercapnic, like they are having trouble breathing, the oxygen level in their body is not enough, you see their hands looking bluish, you will use continuous positive airway. This is CPAP, continuous positive airway pressure. You have to put them on CPAP, or bilateral positive airway, BiPAP, with additional oxygen. So CPAP and BiPAP, let's talk about them. CPAP is continuous positive airway. That's a one-way thing. Mostly the patients go home on CPAP. So you have a patient at home and the patient is on CPAP in the night. So some people, because of sleep apnea, they'll be sitting up sleeping because there's not too much and they cannot sleep. Their neck is too big. They're having problems sleeping, narrowed airway. They cannot sleep. So they need support to be able to have enough oxygen to avoid hypoxic, to avoid being hypoxic. So they get the oxygen. So they put them on CPAP. So at night, they go to bed, they put the CPAP machine on, and then they have a good night's sleep because they'll have enough oxygen supply in their body. The BiPAP is the positive airway pressure. This one is usually in the hospital. They'll put the patient on two-way air pressure, and the patient will be able to breathe better. So for patients with severe cases of sleep apnea syndrome who become hypoxic and hypercapnia, they put them on that. Positioning, you're fixing devices used to prevent tongue obstruction and subluxation of the neck. So you want to be able to help them. Don't put them and then their tongue will go down and block the airway as well. So we have surgery to correct obstruction. Sometimes the patient will need to have a surgical procedure. Then we have low oxygen flow. So you, the nurse, have to give the patient a low level of oxygen. Don't go push too much oxygen into their lungs. You blow up the lungs. Tracheostomy, if life-threatening dysarrhythmias are present, you unplug only during sleep. So you put the patient on track if there is a life-threatening problem. So when you are evaluating a patient, you want to see, has the client's sleep pattern been restored? Can the client sleep peacefully now? Does the client know about how to use the CPAP at home? Does the client know how to use the CPAP machine at home? That's client education. You educate them that you put it in the night. This is the setting. You teach them about the setting on it, and then they use it at night. Let's talk about Alzheimer's disease. Alzheimer's. What is Alzheimer's? This is forgetfulness. When you assess a patient who has this problem, you see that they easily forget. So it's forgetfulness progressing to inability to recognize family faces, places, and objects. So we have different stages of Alzheimer's. And at the fourth stage, the patient is at the last stage of it. The patient no longer recognizes their own family members. They have eating problems. They have communication issues. It's like they are just in the final stages of it. So the second one is they feel depressed. When you assess them, you see that they are depressed, they are paranoid, they are combative. They're paranoid means they are just thinking that everybody that walk past in front of me has something to say about me. You're just thinking, your mind tells you, oh, this one, you're just all over. Okay, they have impulsive behavior, short-term span, short attention span. They cannot give you attention for like 30 minutes. I can only listen to you, but talk within 2 minutes or talk within a minute. Night wandering. Whoa, night wandering. Alzheimer's, remember, night wandering in the night. If you put them to bed and you go to sleep and leave them, before you know, they are out of the house. People with Alzheimer's, they are at risk. They wander at night. Inability to perform daily activities. So you have to tell them. So the person will take the toothbrush and is holding it like, and it's like, what do you want me to do with this? Then you have to orientate them. I want you to put it in your mouth and brush your teeth. So for people with Alzheimer's, you have to constantly reorientate them on a lot of things. Their own house, they get up and they're like, where is the door? Where am I supposed to go out? Where is the bathroom? What am I going to do? They forget. So you have to constantly reorientate and remind them and help them with activities of daily living. Don't think it's intentional. We have the dysphagia, difficulty swallowing, they eat slow, incontinence. They can have urinary incontinence. Then let's talk about diagnosis. How will you diagnose this person? So since Alzheimer's is a progressive, irreversible, degenerative neurological disease that is characterized by loss of cognitive functioning and disturbance in behavior. So it is characterized by loss of cognitive function and disturbance in behavior. They have behavioral problems. The risk factors will be their age, the age of the person, mostly the Alzheimer's, you see that in the elderly population. Family history. So if my mother has had Alzheimer's, you are at risk for getting Alzheimer's as well. The potential nursing problems with these people will be self-care deficit. So Alzheimer's is range from stage 1, 2, and 3, and 4. The fourth one is when they are just at the final stages. The third one, they start losing everything. They start forgetting their own stand, but they have a problem with short memory problems. So the patient finished eating a very beautiful dinner yesterday or a very palatable dinner, and today they cannot remember, but they are able to remember 10 years back when their husband took them out to that restaurant. They're able to remember how they cooked for their kids when they were like 20 years ago. That they will remember. They're able to remember the name they gave it to their children 20 years back, but today the person cannot remember your name. So they know you are their child, but no. Okay, so age, family. Age and family are risk factors for people who get Alzheimer's. Then we have the nursing diagnosis, as I have spoken about. Self-care deficit, they tend to neglect themselves. Like I told you about the activities of daily living and the fact that they forget to do it. Communication and impaired speech. You see that they start having slurred speech, their speech is not clear. They have urine incontinence. Sometimes it's total incontinence, especially in the later stage. They just cannot figure it out when they have to pee. They pee on themselves. Other times you see them sitting down, they start running. I have to pee, and they run to the bathroom. Let's talk about death and when it occurs. So death is as a result of a complication or in the final stages when the person is just not coming back. the mind gradually goes off and the person is not coming back. So death usually will occur in these people due to complications like pneumonia, malnutrition, and dehydration. You have to remind them to drink water. You have to put them on maybe water drinking schedule before they remember they have to drink. So pneumonia is a complication of Alzheimer's, malnutrition, and dehydration. So what will you do for these people? You want to support their cognitive function. So you want to provide them in a calm, predictable environment, and then you present changes gradually. Don't just come and then paint the whole house, or don't just come and then take out or move them from their room and then you take them to a new room that is all fenced and different from what they know. They will get confused. So anytime you have to provide changes for these people, you have to do it gradually. And then you establish a regular routine. You want to establish a regular routine. Then you want to give clear and simple explanations, and you repeat the information for them. This is how you care for Alzheimer's, to support their cognitive function, their thinking ability. Don't talk like 1,000 sentences in 1 minute and you expect them to figure it out. They cannot figure it out because the mind is gradually losing its function. So display clock and calendar. So you want to get a clock and a calendar, and then you put it right in front of their bed. So where the person goes to sleep, the person is facing on the clock. And then the clock, they can read the time and they know it's this time I'm getting up. So color codes, objects, and areas. So you want to also put colors to areas. Then you tell them this is the door. The door color is red. This is the fridge. This is where you sit. You want to color code objects to let them know. So you also want to provide safety. So for these people, helping them with cognitive ability, for somebody who has cognitive impairment issues, you want to remember that they have safety issues. So you also want to provide safety. So as a nurse, it's part of your responsibility to make sure they are safe. Use light and then call light, and low bed and half bed rails. So you have to use call light, low bed. The bed has to be low. Don't go and raise the bed up like this. You expect them to climb over. They are not going to be able to. So you allow smoking only with supervision. Don't let them smoke alone. They will burn the house or they will burn the hospital. So these people, before they smoke, they need somebody to supervise them before they can smoke. You monitor medications and food intake. Don't put all the medications in front of them in the pill box and expect them to take it. Please, for questions in the NCLEX that relate with home care management for these people, please take the safety aspect serious, because if they are presenting this case to you as a home care management, because most Alzheimer's is not it's not like an acute thing, it's a slow progressive thing. Unless something different set in, they rush the person to the hospital. But patients with Alzheimer's, they will always ask questions concerning home care management and safety management precautions. So if you are the nurse, what will you do for this patient if the patient is in the house, or the patient is going to, the patient is in a nursing home? So you want to provide management of safety. You want to make sure the house is a safe place for them, or the environment where they live. So you want to secure doors that leads to the exit of the house. So for some people, you even need to put a doorbell on your door, so that when the person opens, an alarm that will tell you that this door has been opened in this house, so that you will know when the person is leaving the house, so that they don't come out and then they cannot come back. I have taken care of an Alzheimer's patient who walked out of the house and then couldn't figure it out. She didn't know where she was. Right in front of the house, she don't know which one is the house anymore. So mostly these questions will come as home care. Gently distract and redirect during wandering behaviors. So you see them wandering all around the house. So you have to gently redirect them, don't force them. Avoid restraints, increase combativeness. Don't tie them down. So if you tie them down, you are increasing their agitation. They'll fight you all day. So don't tie them down. It's not their fault. Our clients should wear identification bracelet or neck chain. They should wear identification bracelet at all times. They need to have an identification bracelet on their hand so that they can always be identified. Frequent reorientation. It is necessary for safety. Frequently reorientate these patients. Reduce anxiety and agitation. Reinforce positive self-image. Reinforce positive self-image. So this is when you try to look for the person's picture when she got wedded, and then you ask her, oh, do you remember this day? She's gonna tell you, especially in the first and second stage, she's gonna go, oh, this was my wedding day, and this was what happened, and this is how it went. You want to reinforce them, like their self-image, to make them remember who they were. You look for their career picture. When, let's say, the person was a teacher or a pilot, then you get a picture of that person when the person was behind the wheels or on the job. Then you show it. Do you remember this picture? The person is going to be like, oh, I'm a great person, I'm this and that. So sometimes these are memories that you take them back to long term. They're able to remember things that happened years, like I said before, but they cannot remember what they ate this morning for breakfast. It is a normal thing in Alzheimer's. So you reinforce their self-image positive because they forget who they have been before. So you encourage to enjoy simple activities, walking, exercise, socializing. Don't keep them at one place because they already have a problem with wandering around. They don't want to rest. They're just all over. So you encourage them to walk around, to do exercise, to socialize. We have the community groups, the support groups. The elderly people have the day program. You're sending them there to have them do something that will keep their mind busy. Then keep environment simple, familiar, noise-free. Don't go play loud music. The environment should be simple for them to move around, no clusters, things that will cause them to fall. So if clients experience catastrophic reaction or overreaction to excessive stimulation, you have to remain calm and stay with the client. You have to provide distractions such as listening to music, you rock them, or you stroking to quiet client. So for clients who are quiet and you know they are just not within, they're just not what they should be, you try to rock them and then you stroke their back to help. Improve communication. So I have spoken about communication problems before. You have to reduce noise and distractions. You have to use clear, easy sentences for them to understand. And you have to provide lists and simple written instructions. List and simple instructions that is written down for them to follow. You want to also promote independence in ADLs. You don't want to be the one brushing their teeth every day. You want to help them understand. You want to help them to be able to take a shower. You tell them, okay, wash here. Okay, do this, do that. Put on your earrings. Eat. Take the spoon. Cut it small. Put it in your mouth and swallow. You have to be patient with them. So you provide lists and simple written instructions there. So the activities of daily living, you tell them what their plan for the day is, and then you have a list that they can easily access. So you allow them to make their choices when appropriate. So you encourage them to also participate in self-care activities. So for the activities they can do, you help them, you encourage them. And you want to provide for socialization. You encourage letters, visits, 1 to 2 persons at a time. Phone calls, you want to provide a pet. You don't want them to be sitting down and then like 100 people start walking into the house. Then you go there, if they become overexcited or anxious, and they are all over. They become agitated as well, for those who can easily be agitated. Then we have promoting good nutrition. These are things you will do, things you, the nurse, should implement to be able to help these people. You want to promote good nutrition, simple, calm, offer one dish at a time to prevent playing with the food. They can start playing with the food because they don't want it. So one dish at a time, let them finish it before you bring more. You also want to check the food temperature. Don't give them too cold and too hot. So you want to cut food into small pieces to prevent them from choking. You want to use adaptive equipment as needed for feeding themselves. Remember, I spoke about adaptive equipment in the other video, and the interventions that will promote comfort, where you use the plate straps to help them so that the food doesn't move around. So you want to help them with adaptive devices. Provide aprons or smoke instead of beep to respect their dignity. Okay. You know, an elderly person doesn't want to have a beep on their neck. So you don't want to give them a beep. It's too small for their neck. To respect their dignity, you give them a bigger one. That is the apron when they eat. You want to promote balance of activities and rest. Please don't take them to the day room all day and keep them half in the night there as well. You want to balance activities and rest. So you allow the client to work in protected environments. You provide music, warm milk, back rubs to encourage sleep, encourage long naps during the day. You want to provide teaching and support to caregivers. You also want to refer them to Alzheimer's Association, family support groups, adult daycare programs. These are helpful things you can do for the Alzheimer's patient. So complementary and alternative therapies. What will you do for these patients? Complementary and alternative therapies. We have the ginkgo. The ginkgo biloba is a medication that helps with memory problems. So I have that in one of the pharmacology notes. The ginkgo is the one that will help with memory. Then fish that is high in omega-3 fatty acid, then 1,000 international units vitamin E twice daily. These are the pharmacological treatments you want to help, alternative therapies to keep them healthy. Then administer medications such as cholinesterase inhibitors, receptor antagonists, and antidepressants. They are depressed, so you want to give them antidepressants. Evaluation: has the client independence been maintained as much as possible? Because you want to have these people to be independent. Are the caretakers, does the people who take care of these Alzheimer's patients know about how to care for them at home? Now let's talk about thyroid disorders. Thyroid disorders. What are thyroid disorders? When you assess a patient who has a thyroid problem, what will you see? Let's talk about two of them right now. I'm going to talk about mixed edema, and then which is hypothyroidism. And I'm going to talk about Graves' disease. Take note of the difference. We have mixed edema and Graves' disease. One is hypothyroidism, one is hyperthyroidism. I'm just gonna go ahead and share my video so that share my screen so that I can type it in for you. So take note that one is Graves' disease, the other one is mixed edema. So I'm going to discuss the signs for each of that for you shortly. But just give me a minute. Let me share my screen so that we can work together on that. Okay. So I'm sharing my screen. This is what I'm gonna write. One is mixed. Hold on. Mixed edema. Slash hypothyroidism. And then I think I'll put it in a table, in a tabular form, so that you understand the difference between these two and when you are taking care of the patient with that. Okay. Okay. All right. So this is hypothyroidism. And this is Graves' disease. This is Graves' disease. So these are thyroid disorders that you want to take notice of. Let's see. Okay, so Graves' disease is also called hyperthyroidism. And this one is also called hypothyroidism. Okay, please take notice of these differences. Take notice of these differences. So under this one, under mixed edema, there's decreased activity level, hypo. So there's decreased activity level. So since the person's thyroid is not secreting so much, their activity level is decreased. So there is decreased activity level. And here the person is hyper. The person is hyper. Okay? The person have hyperactivity. And here, let me make the font size a little bigger for you. Okay. Okay, so this is hypothyroidism, decreased activities. And the person is sensitive to cold. Sensitive to cold. Here, the person is sensitive to heat. Please take your book and write with me, sensitive to heat. With hypothyroidism, there's a potential alteration in skin integrity. Am I spelling integrity correct? In skin integrity. Here, there's rest and sleep deprivation. There's rest and sleep deprivation. So I'm going down accordingly. So here they have rest. Oh, come on. rest and sleep deprivation. They're not able to sleep or rest. I have a problem with that. Okay. Let's talk about decreased reception to stimuli. They have decreased reception of stimuli. They are obese. The patients who have hypo, they are obese and they have weight gain. They are obese because they have weight gain and they have constipation. Constipation. Then difficulty, potential for respiratory difficulty. Okay, potential for respiratory difficulty or breathing difficulty. Then they have alopecia, loss of hair. Alopecia, loss of hair. They have bradycardia, dry skin and hair. Then decrease. They have decreased ability to perspire, sweating, decreased ability to sweat. Let me use perspire or sweating. They will hardly sweat. Then reproductive system problems. They have reproductive problems, okay? Now let's look at those who have hyperthyroidism. I said they have increased perception to stimuli. So instead of these ones having decreased perception to stimuli, these ones have increased perception to stimuli. They have weight loss. This one have potential. They have weight loss, and these people have diarrhea. Remember, the other group have constipation, they have diarrhea, and this have potential for respiratory difficulty as well. Then they have tachycardia. Tachycardia. Remember the other people, they have bradycardia. Graves' hyperthyroidism is tachy. They have exophthalma. Exophthalma. Or exophthalmos, yeah. That's when their eyes are bulky. We have frequent mood swings. Then nervous and jittery. And they have fine, soft hair. Instead of alopecia, they have fine, soft hair. So these are the differences between the people when you are assessing a patient. So for a patient with hypothyroidism, their basal metabolic rate, their BMR, well, this aspect will be more of the registered nurses to know. So if you are doing RN on the diagnostic testing, their basal metabolic rate will decrease. Okay. their T3, those are the thyroid hormones, T3 will also decrease. Like everybody is decreasing. T3 will also decrease. Then T4, their T4 will also decrease. Then thyroid stimulating hormone, their TSH, will increase. So everybody in this category will decrease except the thyroid stimulating hormone. That will increase. Then in this guy, under Graves' disease, we'll have the body basal BMR, basal metabolic rate. It will increase. Okay. Then we have the well, it's still underlying. I don't want to underline them. Then we have the T3. T3 will increase. Let's see what happened to T2. T4, I'm sorry. T4 will also increase. Ooh, everybody go increasing. Now let's look at the titers anti-thyroid antibodies. So the patient will have high. So when they do the TSH, it will be high titers anti-thyroid antibodies. Okay. So this is what you will find for a patient with hyperthyroidism and hypothyroidism. So take notice. It's not a joke. You have to understand. Okay. All right. So let's continue. I am going to leave this table here and you continue looking at the differences. When you analyze the mixed edema and the Graves' disease, in mixed edema, there will be hyposecretion of the thyroid hormone. That's what it is. And it slows physical and mental functioning. So the thyroid hormone, let me pick it from here. There will be hyposecretion of thyroid hormone. So and this one will cause decrease in activities. It will slow activities, mental function, okay? Activities and mental functioning. And here there will be hyper secretion, too much secretion. So after this one, I'm going to have you take note of the rest. So here, hyper secretion of thyroid hormone. There'll be hyper secretion of thyroid hormone, and this one will make the person hyperactivities. It will cause an acceleration of physical and mental function of an individual. So these are the two differences you want to note. What are the predisposing factors? So at this point, I encourage you to write. Please take your book, take your pen. I'm not going to continue writing this table. I don't want to spend too much time on this video. So the predisposing factors will be inflammation of the thyroid gland for mixed edema or hypothyroidism. The predisposing factors will be inflammation of the thyroid hormone. Inflammation of the thyroid gland. You see the thyroid inflamed. That's why you see like something like a goiter. Then you will have over-treatment with anti-thyroid. This is iatrogenic. We have thyroidectomy. They can do surgery to remove that. So we'll have pituitary deficiency. Your pituitary glands will be deficient, iodine deficiency, and idiopathic. So these are the predisposing factors. If you have too less iodine. So that's why you will hear people encouraging people with thyroid problems to eat salt that contain iodine in it. So if you have iodine deficiency, pituitary deficiency, or you have a thyroidectomy surgery, and you can have low secretion of the thyroid hormone. This can cause hypothyroidism or mixed edema. Now, on the other side, let's talk about Graves' disease or hyperthyroidism. So we have the predisposing factors as thyroid secreting tumors. If there's a tumor in your thyroid gland, that will cause hypersecretion. So you have iatrogenic. You have iatrogenic over-treatment for hypothyroidism. If you treat the hypothyroidism too much of it, if you overdo it, you take too much iodine, you cause higher. So we have pituitary hypersecretion. So when there's a problem in the secretion of the thyroid hormone, that will cause the pituitary gland to secrete too much of the thyroid hormone. So hypersecretion, severe stress and pregnancy. So pregnancy can also cause secretion. We know the hormonal imbalances in pregnancy. So let's talk about treatment and management. So for this one, you want to treat the patient with hormone replacement. It's hormone replacement that you use to treat the hypothyroidism. You know the hormone secretion is low, so you want to do hormone replacement. Okay, so hormone replacement means giving the patient thyroid medication, Synthroid. So the patient takes Synthroid or levothyroid. These are the two medications you give to help replace the hyposecretion of the thyroid hormone. Then for the patients who have the high secretion, your aim is to lower it. So you give anti-thyroid drugs. So we have radiation. We have radiation management, like you have radiation and surgery. They can do surgery to take that out. But anti-thyroid medication are, we have metimazole. This is an anti-thyroid medication. Take notice. Anti-thyroid medication. The thyroid meds. So we have metimazole, propylthiouracil. If you have ever heard this medication, propylthiouracil. Yeah. Propylthiouracil. So this is a thyroid medication, and the next intervention is surgery. Okay, so these are the medications that will help lower the thyroid the hypersecretion of the thyroid hormone. Now let's look at the potential nursing diagnosis. What are you concerned about as a nurse? So you're concerned about disturbed body image. So you know if there's hyposecretion, there's weight gain, you see the patient looking bigger than normal and they keep gaining weight and getting fat and obese. Your body image, we know how much people want to look good, want to lose weight every day. That's what we hear on TV. Then imbalanced nutrition, more than body requirements, eat too much. Then we have activity intolerance, we have constipation, hypothemia, they are always cold. Then we have deficient knowledge, decreased cardiac output because there's too much weight gain, there's pressure on the heart as well. Then on the Graves' disease, hyperthyroidism, there's activity intolerance because you are just hyper all over. You're not able to tolerate activities. Altered body temperature, you are always hot. These people are always hot and they have social interaction impaired. Social interaction problems, they are impaired. Imbalanced nutrition, less than body requirement as well. Hyperthemia, too much heat in them. Fatigue, they will be like they have menopause, menopausal symptoms. We have risk for impaired tissue integrity. So these are the potential nursing problems you want to be concerned about. So if you are taking care of a patient with mixed edema and mixed edema or hypothyroidism or Graves' disease or hyperthyroidism, take notice of the differences and then how to manage each of these patients. Okay, so I'm going to move on to talk about your plan and your implementations. What will you do for this patient? What will you teach this patient for? What will you caution this patient to do? So for a patient who has hypothyroidism, mixed edema, you want to teach them to pace activities. Don't let them boggle up all the activities in one day. Allow client extra time to drink, speak, and act. Your teaching should be done slowly and in simple terms. Then you want to also provide frequent rest period in between activities. You want to maintain room temperature at approximately 75 degrees Fahrenheit. Don't make the room too cold for them. They are already having cold problems, hypothermia. For those with hypothyroidism, that's mixed edema. So you don't want the room to be cold. Provide client. So you know that in the hyperthyroidism, you want to do opposite. You want to keep them in a cold room because they're hot. So you also want to provide clients with extra clothing and bedding materials. You want to, like if they are too cold, you want to provide them with extra blankets and all that. You want to restrict the use of soaps and apply lanolin or creams to skin. They have skin disorders. You want to keep their skin dry. They have skin impairment, risk for skin impairment. So you don't want their skin to be impaired. You try to put lotion. High protein, low calorie diet. High protein, low calorie diet. Take notice of that. What kind of diet will you offer a patient who has hypothyroidism or mixed edema? If they mention mixed edema and do not mention hypo, you need to know that's hypothyroidism. So you want to give them high protein, low calorie diet because they are already gaining too much weight. You don't want them to overgain. So high protein, low calorie. Small frequent feeding, prevent constipation. So to prevent constipation, you want to give this patient high fiber diet, high fiber, high cellulose food. Then you want to increase fluid intake. You want to also give them stool softness if they are ordered. And you want to explain that symptoms are reversible with treatment. You can reverse all those treatments when the patient start taking the levothyroxine and is compliant, the Synthroid, if the patient is compliant. Now you want to administer sedative carefully because there's risk for respiratory depression. And then you instruct the client about the causes of you instruct the client about causes of mixed edema coma. This is a complication, acute illness, surgery, chemotherapy, and discontinuation of medication. So if the patient stops taking the medication, the patient can go into myxedema coma. This is a complication, myxedema coma. So this one, when the patient has myxedema coma, the patient is acutely ill, the patient will need surgery, the patient will need chemotherapy, and the patient will need to discontinue their medication. Let's talk about Graves' disease or hyperthyroidism. Hyperthyroidism, you want to limit activities. They have activity intolerance. So you want these people, you don't want to pace their activities. You just want to limit them as much as possible to quiet ones, activities that will give them some relax. You know, these people are hyper. So reading or knitting. So you give them something and they are weaving out something that give them a little rest. They stay at one place to be able to do something. Provide for frequent rest period, restrict visitors and control choice of roommates. You want to keep room cool, advise light, cool clothing. So don't go and provide them with too or super warm, heavy blanket because you overheat them. Then you want to avoid stimulants. You accept their behaviors. You want to use calm and hurried manner when caring for clients. You want to interpret behavior to their family. You want to administer anti-thyroid medication. You want to provide radiation with short-term or with medication, PO medication, which is usually a short term before they provide treatment. So you want to provide post-thyroidectomy care. So if a patient, for some reason, need to have a thyroidectomy, have their thyroid taken off, you want to place them on a low phallus position, you want to support their neck, and this is surgical management. So they tell you, the oncologist asks you a question, the patient just returned from a surgical procedure for thyroidectomy. What is the best position to put this patient at, or which one will the nurse do first? You position the patient and elevate the head of bed to 30 degrees angle. So tracheostomy set and suction supplies at bedside. This is what you want to do. So the first time you receive the patient, you want to position the patient in semi-phallus position. You want to support the head and the neck and shoulders to prevent flexion, or you hyperextend the sutures that the patient has. You want to make sure that this is not pressing on it. So you elevate the head of the bed to 30 degrees. Then you want to also keep the tracheostomy set at the bedside. Tracheostomy set at the bedside. These are things you will need in case you need to suction or you need to clean, take care of the trach. Then give fluid as tolerated. You want to observe for complications, laryngeal nerve injury detected by hoarseness. So the patient come to you and say, I had a surgery done on my neck 2 days ago, and today I'm talking, my voice is not coming. Hoarseness, you know, anytime a patient you have cold and your voice is gone, it's the larynx that is larynx that is affected. So laryngeal nerve damage will cause hoarseness of voice. This is an emergency in Graves' disease. So thyroid storm. So when you start seeing hoarseness, it's a sign of thyroid storm. Remember thyroid storm you ever had in school? This is increased temperature. So a patient who has thyroid storm will have increased temperature and increased pulse, hypertension, the blood pressure will be high, abdominal pain, diarrhea, confusion, agitated seizures. Treatment will be hypothermia blanket, oxygen, sodium iodine, propylthiouracil, propranolol for the blood pressure, hydrocortisone, antisteroid, corticosteroid, not antisteroid. Then acetaminophen, also caused by trauma if infection is present. Then there'll be palpitations as well. So this is the management of a patient. This is what you would do for a patient that has Graves' disease. And you also want to monitor the patient for hemorrhage. The patient has to go for surgery and come back. Monitor for hemorrhage. You want to check their back, the back of their neck and the upper chest for bleeding, respiratory obstruction. You want to make sure their airways are open. Tetany, decreased calcium and parathyroid involvement. you know that anytime there's an impact on the thyroid, we think calcium. Calcium too will be impacted. So anytime the calcium is impacted, you want to think tetany, a sign called tetany. So tetany is decreased calcium from parathyroid involvement, parathyroid hormone involvement. So you check the patient for chopsticks sign and trousers sign. Then you want to have IV calcium gluconate or IV calcium chloride available. IV calcium gluconate and IV calcium chloride available. Analgesics, cold steam inhalers for sore throat. You're going to give them some cold steam inhalers for sore throat. Adjust diet to new metabolic needs. So you already know that with the thyroid problem, there's problem with metabolism. So you want to adjust their diet to match the metabolic needs of the patient. Evaluation is the client knowledgeable about the dietary considerations. So for a patient with hyperthyroidism, Graves' disease, or mixed edema, or hypothyroidism, you want to make sure they follow a dietary plan. So you want to also be able to control complications. Parathyroid disorders. Let's talk about parathyroid disorders, and we are almost done. So for parathyroid disorders, when you assess a patient who have hypoparathyroid and a patient who have hyperparathyroid, what will you see? So for a patient who have hypoparathyroid problem, you see tetany. That's muscular irritability. They'll have muscle cramps and spasms. They will have chronic convulsion. They'll have dysphagia. They'll have paresthesia, laryngeal spasms as well, anxiety, depression, irritability, tachycardia. There will be positive chopstick sign and trousers sign, positive chopstick sign and trousers sign. Then for a patient with hyperparathyroidism, they will have fatigue, muscle weakness, cardiac dysrhythmias, emotional irritability, renal calculi, back and joints, pathological fractures, then pancreatitis and peptic ulcer. So let's look at diagnosis for a hypoparathyroidism or a hyperparathyroidism. So for a patient with hypoparathyroidism, there will be decreased secretion of the parathyroid hormone, hypo. Then in introgenic, that's post-thyroidectomy, we have hypomagnesemia. Their magnesium will be low. Then diagnostic tests will be serum calcium level will decrease. Their serum calcium level will decrease, serum phosphorus level will increase. Then parathyroid hormone, PTH, parathyroid hormone, PTH will decrease. X-ray, the bones will appear dense. There's a problem with calcium here because parathyroid hormone is involved. So when they do X-ray, bones will be dense. Then let's look at hyperparathyroidism. On diagnostic testing, what will you find when you assess that patient? You will see oversecretion of parathyroid hormone, oversecretion of the parathyroid hormone. There will be benign parathyroid tumor. There will be parathyroid carcinoma as well. There will be neck trauma, neck radiation, and the diagnostic test you want to do for this patient will be, you will see that the serum calcium level will increase. The other one, hypoparathyroidism, the serum calcium level was decreasing. Here in hyperparathyroidism, the serum calcium level will increase. Serum phosphorus level, it increased in hypoparathyroidism, but in hyperparathyroidism, it decreases. So serum phosphorus level will decrease. X-ray, bones appear porous. They appear porous, not dense. They are porous in hyperparathyroidism. Then serum parathyroid hormone will increase. PTH will increase. The other one in the hypoparathyroidism, PTH was decreasing. Now, potential nursing problems that you want to tackle is risk for injury in a patient with hypoparathyroidism. They are at risk for injury, and deficient knowledge deficit. Then for a patient with hyperparathyroidism, they are also at risk for injury. They have impaired urinary elimination, urinary problems. They have nutritional problems as well, and they have constipation. What will be your plan? Your emergency treatment will be calcium chloride or calcium gluconate over 10 to 15 minutes for a patient with hypoparathyroidism. I just wish you could get a book to write these differences. So for a patient with hypoparathyroidism, they need emergency management, and the emergency treatment will be calcium chloride or calcium gluconate, and that is given 10 to 15 minutes. We have calcitriol, that's Recaltrol. This is 0.5 to 2 milligram daily for acute hypocalcemia. This is a medication. It's a calcium-containing medication to help bring up the calcium level in the body. So this is for acute hypocalcemia. Then we have egocalciferol. This is usually they call that vitamin D. Egocalciferol, 5,000 to 400 million units daily. So you give the patient vitamin D daily. You want to observe for tetany, positive chopsticks, and positive trousers sign. So low phosphorus, high calcium diet. You want to encourage for low phosphorus diet, high calcium diet. Then you want to relieve pain in patients with hyperparathyroidism, pain. So those with hyper, their plan will be pain relief. Their plan will be to prevent them from renal calculi. Remember, I said they have renal problem because they have too much of calcium in their body. So everything is off on that aspect. We want to increase fluid. You want to offer acid ash juice. That's improve solubility of calcium. You want to give them acidic juice that will help the solubility of calcium, reduce it. Administer appropriate diet. You want to prevent fractures. That's safety precautions, and you want to monitor the potassium level. So counteract effect of calcium or cardiac muscles. So if the potassium levels too are low, it will now counteract the effect of calcium on the cardiac muscle. You want to provide post-parathyroidectomy care. Essentially, this is the same as thyroidectomy. So you want to provide that. I had mentioned that you want to give the patient laces. You want to give them saline to promote calcium excretion. That's why you are promoting hydration in the first place as well. So IV phosphorus is used only for rapid lowering of calcium level. And then surgery, which is parathyroidectomy, is recommended for this patient. So when you want to evaluate this patient, your aim should be, has the client's mobility been maintained, and has the client been able to be free from any complications? So this brings me to the end of our topic, rest and sleep. Rest and sleep disturbances. All along, I have been talking about problems that will affect rest and sleep. And the main points I spoke about, the main diseases I spoke about is thyroid disorders. I moved in to talk about thyroid disorders. I spoke about Alzheimer's. I spoke about sleep apnea. I spoke about the elderly client. I spoke about the hospitalized client first. Let me arrange them for you to get it. So first of all, I spoke about the hospitalized client and what you need to do for them. I spoke about the elderly client. I spoke about sleep apnea syndrome. That's snoring. Patients with snoring problems. How will you handle that? Snoring disorders. Then I spoke about Alzheimer's patients, Alzheimer's disease, mostly in the elderly. Then I spoke about thyroid disorders. And under thyroid disorders, I spoke about 4 of them. And that's what you need to know for the NCLEX. So for the thyroid disorders, I spoke about mixed edema, which is also the same as hypothyroidism. I also spoke about Graves' disease, which is the same as hyperthyroidism. Then I went further to talk about parathyroid disorders, which is hypoparathyroidism, and hyperparathyroidism. Please get the difference in these 4 problems of the thyroid. Our next topic, which will be our video number 6, will be on nutrition. I am still talking about physiological integrity. Please make time to watch these videos. I know they are sometimes long, but this is just a portion of your test plan that you need to understand. So if you haven't studied these conditions before, this is an opportunity for you to get to know what point you should look out for before you go and sit in for the exams. Thank you so much for actually making time to watch with me. It is my pleasure. It's my pleasure to have you watch, and you can repeat this video if you didn't watch it from the beginning. Please repeat the video. Even if you watch it from the beginning and you need to understand, please watch it over and over. It is for you to understand, and you have to pass this exam. You have this information at your hand. All you just need to know is to exhaust it and understand it. You can listen to these videos as easy as you can. It's on your phone, it's easy, mobile, you can move with it and everything. So thank you so much for staying with me, and watch out for video number 6 and 7 under physiological integrity. Have a good day. Thank you. Bye-bye.